Hi, my name is Connie Koklanis and you're watching the video Orbital Injuries Classification. In this video, we'll be specifically talking about blowout fractures and how to go about classifying the fracture that the patient has. So the first thing to do is to work out if you have a pure or impure blowout fracture. The distinction here is the rim of the orbit and whether it is intact or not. So with a pure blowout fracture, essentially the fracture is within the orbit and the rim is intact. However, with an impure fracture, what we have is the rim is not intact. If we have a look at the scan over here, we can see that the orbital floor here has been fractured, and we can see tissue has prolapsed here into the maxillary sinus. So in this particular instance, we have an impure blowout fracture where the orbital rim is not intact. Generally speaking, more severe injuries will cause an impure blowout fracture. So examples of severe trauma are things like industrial accidents or motor vehicle accidents, as compared to a assault, for instance. A fist to the eye generally may more often cause a fracture within the orbit rather than fracturing the rim. The next thing to classify is determine which wall has been fractured, or walls. Sometimes it can be multiple. So let's start off with the floor. If you have a floor blowout fracture, you call it either a floor blowout fracture or an antral blowout fracture. And in the scan here, we can see that this individual has a floor blowout fracture of the left eye, and we have prolapse of tissue here as well. The patient here, who has a right injury, also has a floor blowout fracture, but we can't tell that from the photograph. That patient would need to be scanned in order for us to determine whether the floor has been fractured or not. Now, the floor of the orbit is actually the most commonly fractured of all the walls of the orbit. And the reason is that it's at high risk of being fractured because it sits over the maxillary sinuses. And so we can see here the floor is just above the maxillary sinus in here, which puts it at risk as there is space beneath it. Now, we can further subclassify floor blowout fractures. Not all clinicians subclassify in this way, but you can do so. But it might help you think about the types of limitations that a floor blowout fracture can result in. So type 1, we have limited elevation of the affected eye, and this is due to a mechanical restriction. Type 2, it's actually the opposite. We have a limitation of depression, and now this is due to a inferior rectus palsy or a flap tear. And 3, we actually have a combination of both elevation and depression being affected due to either mechanical restriction or also inferior rectus palsies or flap tears. Another classification that I want to bring your attention to is the wide eye or trapdoor fracture. This occurs in young children or young adults where the bones are more flexible, and what happens is that they snap back and entrap tissue quite differently to the way in which occurs in other blowout fractures. And what can occur in this instance is that the patient will have an entrapment of the extraocular muscle, for instance, of the inferior rectus, but without many of the signs that we would otherwise see, so the swelling or the hemorrhaging. So the eye appears white and quiet, even though there's a fracture and muscle entrapment. If we look over to the right here, this individual actually has a wide eye fracture. And this is a 15-year-old teenager, and you can see that there is very little signs of trauma here, and you can just see some bruising, but no significant bruising. We can't see hemorrhaging. There isn't really significant amounts of swelling. But as the teenager looks up, there is significant limitation of elevation of that right eye. Okay, this is the wide eye fracture. This is also a good example of what I was saying earlier, where in primary position you may have straight eyes and significant limitation when you move the patient into the position of limitation. This doesn't occur in or doesn't generally occur in neurogenic palsies. If you have a limitation in eye movement, it usually has an effect in prime position. It might be a fore error if it's controlled, but there should be a deviation in prime position. The next most commonly affected wall is the medial wall. And we can see why if we have a look at this particular image here. We can see that the medial wall is just adjacent to the ethmoid sinus. So again, it's vulnerable to being fractured. It is indeed also the thinnest of all the orbital plates, so it's at high risk. It's rare to occur in isolation and often occurs with a blowout fracture of the floor. So it's not uncommon to see both a floor and medial wall fracture, and here we see such an instance. Okay, a medial wall fracture generally causes issues horizontally in terms of ocular movements. So we'll see limitation in abduction. The general rule, as we've talked about, is that the limitation will often be, not always, but often be in the opposite direction to where the fracture is. So here, in this particular patient, there's a medial wall fracture, and we can see that the patient has issues abducting the eye. Now, there could also be limitation of adduction, and in this instance, it could be mechanical. It could be a medial rectus flaptor, or it could actually also be neurogenic from the trauma and not be due to mechanical restriction, as an example, and be due to a mechanical rectus palsy. Okay, now we're moving to the least common blowout fractures, and we'll start off with the roof. Now, the roof uncommonly is affected and will occur if you have a high velocity trauma, or is more likely to occur with a high velocity trauma. The patient here to the right, we can see that the CT scans are indicating fractures of the roof here. Here's another image of the same, and here we can see the fractures of that roof. Where the roof has been affected, often the levator and the superior rectus will be the muscles that will be impacted. So you could end up with ptosis, hypertropia are not uncommon. And one of the common findings is upgaze issues or issues in relation to elevation are not uncommon in patients who do have roof fractures. And lastly, the lateral wall. This is the thickest wall and therefore is very rare to see being affected. But we do have a CT scan here of a patient who's had a fracture here of the lateral wall of the orbit. So it generally affects the rim and is impure, and again you're looking at a relatively large injury that's causing this particular wall to fracture. Okay, so classification is based on which wall has been fractured, either the floor, the medial wall, roof or lateral, and whether the rear is intact, in which case we indicate whether we have a pure or impure orbital fracture. And note that you can have more than one bone being fractured, and more often than not, the two that are affected together are the floor and the medial wall as being the most vulnerable to fractures. Okay, that brings us to the conclusion of this video. Thank you for watching.